I appreciate the opportunity to present very applicable applications of estrogen receptor targeted PET imaging using Cerianna, also known as fluoroestradiol. These are required disclaimers that say that the communication and the information communicated during this presentation is intended in good faith, to be truthful and non-misleading, and presented in a fair balance. And this is information should not be copied or shared without express permission from Xyonexo or GE. And that Cerianna is a radioactive diagnostic agent indicated for use with positron emission tomography imaging for the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. And that in over 1,000 patients, there was a less than 1% rate of injection site pain or changes in the sensation of taste. So a very important problem in medicine is that invasive lobular carcinomas can be harder to detect and quantify than other breast malignancies. It is becoming increasingly well known that not all breast cancers are the same. The most common histology of breast cancer is invasive ductal breast cancer, which accounts for about 80% of breast cancers. But the second most common breast cancer, invasive lobular breast cancer, accounts for about 15% of breast cancers and is genetically, pathologically, and clinically distinct from the more common invasive ductal breast cancer. In particular, invasive lobular breast cancers have loss of a gene known as CDH1, which encodes for E-cadherin, which is a cell adhesion molecule. So it helps hold the cancer cell cluster together. Thus, while invasive ductal breast cancers tend to grow in coherent balls of tumors, invasive lobular breast cancers tend to grow in lines or sheets or fingers of tumor cells, so that there are fewer tumor cells in any given volume of tissue. And this makes invasive lobular breast cancer more difficult to detect on virtually every imaging modality currently utilized in the clinic, including mammography, ultrasound, breast MR, and FDG PET. Here are just a few examples of this problem, which we have visualizing invasive lobular breast cancer. It makes it much more difficult to visualize invasive lobular breast cancers as compared to the more common ductal breast malignancies. Here we have FDG PET, axial FDG PET, CT, and fused FDG PET images in a patient with a malignancy in the right breast, which is actually quite extensive, but it's not visualized on either the FDG PET or the CT. Whereas mammography can show that this is a 4-quadrant breast malignancy. Despite vast quantities of the breast being visualized, it's neither apparent on the CT scan and does not take up enough FDG to be recognized on FDG PET. Now, FDG PET CT, its greatest uses is not within the breast itself, but rather for distant metastases. But even here, lobular breast cancer presents substantial challenges. Here is the maximum intensity projection image from an FDG PET on a patient with lobular breast malignancy, as well as the axial CT and fused FDG PET CT images. And we can see there are no abnormal FDG foci on this scan. However, the CT shows us multiple sclerotic osseous lesions. Are these non-FDG avid metastases in the bone? Are these benign bone islands? Very difficult to distinguish from one set of images. This particular patient had additional imaging from before and after their diagnosis of breast cancer, demonstrating that these osseous lesions are new since their diagnosis of breast cancer. And then biopsy was used to confirm that these are indeed multifocal osseous metastases that are just not avid on FDG PET. So the the lobular breast cancers are shown not only within the breast, but also at sites of distant metastases, more difficult to visualize on FDG PET. And indeed, this is probably the most extensive example of this that I have encountered. Another patient with invasive lobular breast cancer with no abnormalities on the FDG PET, but widespread sclerotic osseous lesions at initial diagnosis. So this is not treated disease. This is initial diagnosis. This is widespread osseous metastases, just not avid enough for FDG in order to show on an FDG PET. And this doesn't just apply within the bone, but also applies to soft tissues, where a large soft tissue massage, such as this one in the axilla, can be detected sometimes on anatomic imaging with virtually no FDG avidity to show for it. So there are multiple manuscripts now demonstrating that a valuable imaging method, FDG PET, for detecting metastatic breast cancer is not as valuable in invasive lobular breast cancer as it is in invasive ductal breast cancer. And this is a problem. If we can't use some of our most valuable tools in invasive lobular breast cancer, what do we do next? Well, nuclear medicine is evolving into a field of targeted molecular imaging, where tumor cells express specific targets, such as in breast cancer, the estrogen receptor. And we can design binding agents that bind to those targets, much like a key fitting into a lock. So with a binding agent that binds to the estrogen receptor, we can specifically bind to the estrogen receptor and detect breast cancer while not detecting non-breast cancer lesions. We can link that binding agent to a radioisotope that emits small amounts of radiation, such as fluorine-18. And this key that we've now built, a binding agent linked to a radioisotope, allows us to image estrogen receptor and thus estrogen receptor expressing breast cancers using a machine such as a positron emission tomography scanner. So in the case of estrogen receptor targeted imaging, our target is the breast cancer cell expressing the estrogen receptor. The binding agent in this case is specifically is estrogen, which is already physiologically seen in everyone's body. We link to the estrogen, the fluorine-18 radioisotope, and we now have a key that can emit positrons that can be detected on a PET scanner and that specifically bind to the estrogen receptor, allowing us to visualize estrogen receptor expressing breast cancer tumors. Now, this agent that has been created, the key and the radioisotope, 18F-fluoroestradiol, is currently commercially available under the trade name Cerianna. The research in Cerianna, or 18F-fluoroestradiol, has over a period of decades demonstrated that this agent can estrogen receptor positive lesions and correlate with estrogen receptor expression on immunohistochemistry. So what we see in immunohistochemistry on the pathology correlates with Cerianna avidity on Cerianna PET scans. Using Cerianna in this way allows us to non-invasively assess the entire body for estrogen receptor expressing malignancy, as opposed to a biopsy, which may sample one site and do it invasively, requiring a medical procedure and biopsy. The Cerianna PET scan can assess from head to leg estrogen expression within the entire body without any invasive procedure. And particularly for invasive lobular breast cancer, as nearly all invasive lobular breast cancers are estrogen receptor positive, Cerianna PET presents us an opportunity to visualize invasive lobular breast cancer in a way that previously may not have been possible. So let me show you what the Cerianna, or this FES PET scan, looks like on imaging. This is the normal distribution of Cerianna displayed in a maximum intensity projection images, or MIP image, from a Cerianna PET scan. We expect to see Cerianna be held up a little bit in the vasculature, in the veins, in the extremity where it is injected. Cerianna is excreted through the liver, through the biliary tree, into the bowel. So we will see these structures in each scan as physiologic expression of Cerianna. And we will, to a lesser extent, Cerianna is excreted through the kidney into the ureters and bladder. So we expect to see these structures as well. Important to note, because there is so much physiologic uptake and excretion in the liver, it can be very difficult to evaluate the liver on a Cerianna PET. So I recommend, for those who are going to be interpreting these images, take full opportunity to extend the PET window so that you can see individual sites of Cerianna uptake beyond physiologic avidity within the liver. This is what a Cerianna PET scan appears like on cross-sectional imaging. Again, here is a MIP image, the maximum intensity projected image showing the liver and bowel. We'll go through some of this abnormal uptake now in the bones. Here is the cross-sectional FES or Cerianna PET image, the axial CT image, and the fused FES PET CT image. As we scroll through the head, into the chest, and then further down into the abdomen, we can see that extensive physiologic uptake excretion in the liver, the excretion of the agent into the biliary tree. We can also see the renal collecting systems as it's excreted through the kidneys, and the biliary excretion into the bowel. We also see abnormal collections of tracer, uptake of tracer in multiple osseous lesions. So while we recognize the physiologic uptake of the agent in the liver, bowel, and kidneys, these multiple foci in the bones are abnormal and represent estrogen receptor positive tumor that are being sensitively detected by the Cerianna. Let's talk about some applications that can be used, that Cerianna can be used for in the clinic today. The first, and I think most important, is to detect estrogen receptor status in recurrent or metastatic lesions. Let's go through that in a few images. Here, for example, is a patient with a known estrogen receptor positive metastatic breast cancer. The patient is progressing on a first-line estrogen receptor targeted therapy. And the medical oncologist asks, should we utilize a second-line estrogen receptor targeted therapy in this patient, or should we forgo that and move on to other lines of therapy, such as chemotherapy? Well, this patient is known to have progressing disease, yet on the Cerianna PET scan, we only see the physiologic uptake of tracer. And the disease that we can see on anatomic imaging is not Cerianna avid. This tells us that even though this patient may be estrogen receptor positive, the estrogen receptor is not accessible to drugs like Cerianna. Similarly, another patient with estrogen receptor positive metastatic breast cancer progressing on first-line estrogen receptor targeted therapy. And this patient had an FDG PET, a PET scan that evaluates metabolism, demonstrating increasing osseous and hepatic malignancy. This patient then undergoes a Cerianna PET scan. And again, even though the disease is visible on FDG PET, the estrogen receptor in the tumors is not accessible to the Cerianna. So in this instance, the Cerianna is not being used to determine the extent of disease in these patients. That's what the FDG PET is for, or that's what the CT and bone scan is for, determining whether the disease is getting bigger or smaller. Here's the other side that could be seen on a Cerianna PET scan. Same clinical scenario, ER positive metastatic breast cancer, which is progressing. But in this case, the patient's disease is Cerianna avid. This is a very interesting patient with estrogen receptor positive metastatic breast cancer, again, progressing on a first-line ER targeted therapy with multiple FDG avid osseous metastases. So the FDG PET tells us there's substantial disease that's increasing. We get a Cerianna PET, but very interestingly, some of the lesions are avid, and I want to zoom in on a few of these. There's one lesion we're going to zoom in on in the left ileum, and one lesion in the right ileum. The lesion in the left ileum is not FDG avid, but is Cerianna avid. And when this lesion is biopsied, it shows that this lesion is estrogen receptor positive. Whereas the lesion in the right ileum is FDG avid, but not Cerianna avid. And this lesion is biopsied and demonstrates that it's estrogen receptor negative. So as a review here, let's go through two more patients presented by Boers et al. On a more recent publication of patients with metastatic breast cancer that go on therapy with a current estrogen receptor targeted therapy with a aromatase inhibitor and a CDK4/6 inhibitor. The FDG PET shows us the extent of disease, and there are multiple FDG avid lesions. And again, the FDG PET can show a reduction of disease post-therapy. Contrast that with this other patient who has multiple osseous lesions demonstrated on the FDG PET. The Cerianna or the FBS PET, these lesions are not Cerianna avid. The FDG PET post-treatment demonstrates that the patient does not respond to estrogen receptor targeted therapy. To me, this is remarkable. Imaging has traditionally been to find the malignant lesions in imaging in oncology, and then to determine if the lesions are getting worse or better. But here, the Cerianna PET is doing an entirely different job. I'll quickly go through a few other potential applications of Cerianna PET, not so much in detail. For number two, we can use the Cerianna PET to help assess estrogen receptor status in lesions that may be difficult or to biopsy, or lesions we just don't want to biopsy. For example, this patient with a lesion in the brain parenchyma could be morbid to perform a needle biopsy of this lesion. But the Cerianna PET can be used in lieu of tissue sampling, in lieu of biopsy, to help show us that this indeed is an estrogen receptor positive lesion, likely to be an estrogen receptor positive metastasis in this patient with known estrogen receptor positive primary malignancy. A third potential application of Cerianna PET is to detect estrogen receptor expressing disease when we have inconclusive results on other imaging modalities. So the standard bone scans or CT scans, we may not be sure, is that a metastasis? Is that not a metastasis? For these patients, we can use Cerianna PET, which will likely be more specific for estrogen receptor positive breast cancer to help answer questions when other imaging studies are inconclusive. This retrospective study from Bors et al. Suggested that in over 85% of cases that were unclear on traditional imaging such as CT and bone scan, the Cerianna PET scan could better answer questions about whether lesions are benign or malignant in patients with breast cancer. Now, indications 1, 2, and 3 can be used for invasive ductal as well as invasive lobular breast cancer. This number 4 may be more specific towards invasive lobular breast cancer, because for evaluating the extent of disease in tumors that are metabolically active and thus FDG avid, the FDG will do a fine job evaluating extent of disease. But some breast cancers that are less metabolically active, such as invasive lobular breast cancer, which we showed earlier, the data for, the Cerianna PET may be able to better assess the extent of disease better in these tumors than the more standard FDG PET. Let me show you a few case examples for this. A patient with estrogen receptor lobular breast cancer has a suspected chest wall recurrence. The FDG PET CT shows one small focus, which turns out to be the left chest wall recurrence. But the Cerianna, the estrogen receptor targeted PET, unfortunately is able to identify multiple sites of osseous as well as soft tissue disease. So the Cerianna PET does a superior job of detecting the extent of disease in this patient with invasive lobular cancer. Similarly, this is another patient with estrogen receptor positive lobular breast cancer and an increasing tumor marker. And the FDG PET was performed in order to evaluate for the site of recurrence. What was called was SPG avid lung lesions, which were biopsied, and this turned out to be benign infectious inflammatory granulomatous disease. And this is one of the problems with FDG PET. Not everything that's FDG avid is cancer. Infectious processes, particularly granulomatous processes, can be very FDG avid and can mimic malignancy on an FDG PET. After the biopsy of a lung lesion showed that the lung lesions were benign in this patient, the patient went on to a Cerianna ER-targeted breast cancer, ER-targeted PET imaging. And in this patient, the inflammatory lung lesions are not Cerianna avid because these granulomatous lesions don't express estrogen receptor. However, there were unfortunately multiple sites of disease, including nodes, the GI tract, osseous lesions, and peritoneal lesions, which was subsequently biopsy proven to represent this patient's recurrent invasive lobular breast cancer. So there is retrospective, here's a retrospective study, and growing prospective evidence that estrogen receptor targeted imaging with Cerianna may help evaluate extent of disease in patients with estrogen receptor positive lobular breast cancer. And this is from a manuscript that we published. This one is retrospective, but in the vast majority of patients, the Cerianna or FES PET was able to determine extent of disease. In some patients where the FDG PET had no lesions, the Cerianna was the only PET scan to demonstrate the sites of disease. So in summary, molecular imaging is making key advancements in taking care of patients with malignancy. And specifically for this talk, estrogen receptor targeted imaging with fluoroestradiol, commercially available as Cerianna, is an FDA-approved PET agent with a growing role in the clinical assessment of patients with estrogen receptor positive breast cancer. And we discussed several potential applications for Cerianna PET. We discussed using Cerianna to evaluate the estrogen receptor status in recurrent or metastatic lesions. We said that Cerianna can help assess estrogen receptor status in lesions that you may not want to biopsy, such as brain lesions. We said that Cerianna can help answer questions about estrogen receptor positive disease, the presence of estrogen receptor positive disease, when conventional imaging studies like CT and bone scan are inconclusive. And we said there is probably going to be a growing role for using Cerianna for assessment of the extent of disease, particularly in patients that have tumors that may not be very metabolically active and thus well evaluated by FDG PET, such as patients with lobular breast cancers, which may be more easily disease mobilized with ER-targeted Cerianna PET.
Important safety information, indications and usage. Cerianna is indicated for use with positron emission tomography, PET imaging, for the detection of estrogen receptor ER-positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. Limitations of use. Tissue biopsy should be used to confirm recurrence of breast cancer and to verify ER status by pathology. Cerianna is not useful for imaging other receptors, such as human epidermal growth factor receptor 2, HER2, and the progesterone receptor, PR. Contraindications, none. Warnings and precautions. Risk of misdiagnosis. Inadequate tumor characterization and other ER-positive pathology. Breast cancer may be heterogeneous within patients and across time. Cerianna images ER and is not useful in imaging other receptors, such as HER2 and PR. The uptake of fluoroestradiol F18 is not specific for breast cancer and may occur in a variety of ER-positive tumors that arise outside the breast, including the uterus and ovaries. Do not use Cerianna in lieu of biopsy when biopsy is indicated in patients with recurrent or metastatic breast cancer. False negative Cerianna scan. A negative Cerianna scan does not rule out ER-positive breast cancer. Pathology or clinical characteristics that suggest a patient may benefit from systematic hormone therapy should take precedence over a discordant negative Cerianna scan. Radiation risks. Diagnostic radiopharmaceuticals, including Cerianna, expose patients to radiation. Radiation exposure is associated with dose-dependent increased risk of cancer. Ensure safe drug handling and patient preparation procedures, including adequate hydration and voiding to protect patients and healthcare providers from unintentional radiation exposure. Pregnancy status. Assessment of pregnancy status is recommended in females of reproductive potential before administering Cerianna. Adverse reactions. In clinical trials of an N of 1,207, the most common adverse reactions seen occurred at a rate of less than 1% were injection site pain and diagnosia. Use in specific populations. Pregnancy. Risk summary. All radiopharmaceuticals, including Cerianna, have the potential to cause fetal harm depending on the fetal stage of development and the magnitude of radiation dose. Advise a pregnant woman of the potential risk of fetal exposure to radiation from administration of Cerianna. There is no available data on Cerianna use in pregnant women. No animal reproduction studies using fluoroestradiol F18 have been conducted to evaluate its effect on female reproduction and embryo fetal development. The estimated background risk of major birth defects and miscarriage for the indicated populations is unknown. All pregnancies have a background risk of birth defects, loss, or other adverse outcomes. In the US general population, the estimated background risk of major birth defects and miscarriage in clinically recognized pregnancies is 2 to 4% and 15 to 20%, respectively. Lactation risk summary. There's no data on the presence of fluoroestradiol F18 in human milk or its effects on the breastfed infant or milk production. Lactation studies have not been conducted in animals. Advise lactating women to avoid breastfeeding for 4 hours after Cerianna administration in order to minimize radiation exposure to breastfed infant. Pediatric use. The safety and effectiveness of Cerianna in pediatric patients has not been established. Geriatric use. Clinical studies of fluoroestradiol F18 injection did not reveal any difference in pharmacokinetics or biodistribution in patients aged 65 and over. Drug interactions. Systematic endocrine therapies that target estrogen receptors. Certain classes of systematic endocrine therapies, including ER modulators and ER downregulators, block ER, reduce the uptake of fluoroestradiol F18, and may reduce detection of ER-positive lesions after administration of Cerianna. Drugs from these classes, such as tamoxifen and fulvestrant, may block ER for up to 8 and 24 weeks, respectively. Do not delay indicated therapy in order to administer Cerianna. Administer Cerianna prior to starting systemic endocrine therapies that block ER. To report suspected adverse reactions, contact Xianexa US Corp., a GE healthcare company, at 1-844-946-6392 or FDA at 1-800-FDA-1088 or fda.gov/medwatch. For information related to Cerianna, please email your inquiries to medicalaffairs@xianexa.com. Thank you for your participation in this event and your interest in Cerianna.